Good afternoon, everyone, and thank you for joining today's presentation. My name is Chris Duff, and I'm a disability practice and policy consultant who has been working with the Lewin Group to develop the Disability Competent Care Model and related webinars and materials. On behalf of the Lewin Group, I would like to welcome you to our Disability Competent webinar series. The Medicare and Medicaid Coordination Office, the Centers for Medicare and Medicaid Services, has contracted with Lewin to develop technical assistance and actionable tools to support providers in their efforts to deliver more integrated, coordinated care to Medicare and Medicaid enrollees. This series will consist of 7 webinars running on Wednesdays at this time through March 22nd. All the webinars are being recorded and will be available along with a PDF of the slides at the Resources for Integrated Care website, referenced at the bottom of this slide. In 2013, we published a comprehensive disability competent care self-assessment tool describing disability competent care and produced 25 webinars on the topic, along with numerous supporting tools and documents. These are also available on the RIC website. The DCC material has recently been revised to be more accessible to users and reflect the further development of the field. It is now structured into 7 pillars of disability competency. In this series, we are introducing the 7 pillars with a webinar dedicated to each. We will be allowing at least 15 minutes at the end of each presentation for discussion and questions. As you can see in this slide, today's presentation is on the 2nd pillar, participant engagement. We would like to solicit your opinion on this series as well as past webinars and supplemental resources. Please take the time to complete our survey at the end of this webinar and send us your ideas for future topics and content. Contact information is listed at the end of this presentation. Today, we will encourage you to understand the participant experience. While each individual is unique, they have some common experiences. Most experience barriers to care, whether access, communication, sensory, or others. With understanding, we will be able to support them as they need. This is the means to establishing an essential relationship with each participant. The main body of this pillar is the assessment itself, the content, process, and outcome. This is where you get to know the participant from their perspective. Besides basic history, solicit their goals and priorities. From this assessment, disability competent care providers, in partnership with the participant, can develop an initial care plan. The involvement of care partners is incorporated into the participant's care plan. As I shared in the presentation last week, the relationship you are able to develop with the participant is the key to success. With a strong relationship, the participant and their team will be able to move forward in concert with open communication and a joint commitment to the identified goals and plans. Without this relationship, participants commonly become disengaged or feel their health and health care are in someone else's hands. The results can be a lack of follow-through, withholding of key information, and frustration on behalf of both the participant, the interdisciplinary team, and their providers. Many of us have found ourselves in this position. If so, I encourage you to stop and try to put yourself in your participant's position. I have found this gives me insight into why they are doing as they are and gives me a new way to approach them in the situation. Somehow you need to disengage from the conflict As stated earlier, establishing a relationship requires actively listening to both their stories and experiences, as well as careful review of their complete profile and records. Ask them questions to engage them to talk about their history. When they were born, where did they grow up? Ask about their family. Ask them about what they would like to have different in their life in the next year. Try to get a sense of their social support system, family, friends, colleagues, and others. Have they been active in a church, an athletic league, or community activities? Ask them what they would like to do with their free time. This will all give you a sense of who they are and, most importantly, show that you care enough to get to know them as a person. Lastly, and I place this intentionally last, inquire of their health and health history. Getting to know them first as an individual helps to keep their health and disability in perspective. It is important to obtain their health history, but even more important to obtain their experience of their health and how it affects their functioning. Through this initial conversation, to get to know the participant, you will certainly hear about barriers they have experienced. These barriers and these health and other barriers commonly lead to frustration and health disparities. In the disability competent care model, these barriers are characterized as attitudinal, access, communication, and programmatic. As with other disenfranchised groups, they have a culture of their own, created out of a common understanding and experience. Some may withdraw due to these barriers, feeling isolated and frustrated. Some may become angry, while others may find alternative ways to get their needs met. That said, the first step of disability competent care is to simply listen to them, understand their experiences, frustrations, barriers, and needs. The next pillar in this webinar series will focus solely, this next pillar and the next webinar in this series will focus solely on these barriers to care. Research has repeatedly shown that persons living with disabilities experience a range of health disparities. Most all of them are related to the issues I reviewed in the last slide. The result is inadequate care and poor outcomes. For example, a person with disabilities commonly experiences difficulty or delays in receiving necessary care, and they fall short of targets and rates of important screening tests. Due to difficulty obtaining primary care services and reliance on specialists, their preventive care is often neglected. Many have not had dental care and don't routinely receive relevant sexual health information. Even something as basic as hypertension is not identified and addressed at the same rates as with the broader population. There are also a variety of social factors that impact health status and outcomes. Many people with disabilities rely on Medicaid and or Medicare for their health care. These programs are going through extensive redesign, moving from fee-for-service to value-based purchasing. As these payers are beginning to focus on outcome measures, such as cancer screening, vaccination, diabetes management, and so on, the clinical interventions are straightforward, but communication and service delivery stretch the disability competence of many providers. Of course, many of these are directly related to the access issues I discussed earlier. Add to that the financial, eligibility, transportation, and other challenges. It is no wonder they experience poorer outcomes. The health of persons with disabilities is at stake due to these factors. For many providers and plans, improving outcomes for disabilities will have direct impact on revenue, and therefore it behooves them to also attend to these related barriers. The goal at this point in your relationship with the participant is to establish a partnership in addressing their barriers and healthcare needs. Make the discussion participant-centered, focusing on their life, their needs, their goals. Be aware of barriers that exist in the living environment, from as simple as floor surfaces to an inability to access water. It's good to remember that the barriers you perceive may be different than the ones they perceive. Be open to learning about their experience, for they may have developed a very functional workaround, and then share your observations. Perhaps the hardest to understand and appreciate are the attitudinal barriers many people with disabilities experience. These interactions can simply wear a person down, and they stop trying. Again, the result is a missed opportunity for quality outcomes. There'll be more on this in next week's webinar. Talking with a participant about their healthcare services and experiences will give you insight into their ability to get their needs met and the level and nature of supports they need. Ask if they have had avoidable ER visits or even hospitalization. By avoidable, I mean those that could have been prevented if the participant was able to obtain the care they needed and at the right time. Examples of this are UTIs and respiratory infections. Is their home care and living setting stable or inconsistent and chaotic? Ask whether they can rely on having their needs met on a routine basis. Observe how actively they participate. The participant is able to participate in the assessment. Or do they seem to have a limited understanding of their needs and functioning? Do they even have an active primary care physician relationship? Or are they relying on specialists for most of their care? While specialists provide very important services, they commonly don't focus on prevention and are not linked to the interest of their team or other physicians. Many people with disabilities, and I'm thinking of people with MS in particular, their primary physician tends to be neurologists, for they're the ones who they see most frequently regarding their disability. But neurologists traditionally do not address all the preventive services that everyone needs. Lastly, and very importantly, there are formal and informal support systems in place. More on that concept of care partners at the end of this presentation. This slide provides a series of tips to help the participant direct their care. You can go over the list on your own, but many of them are simple tips to share with participants. Suggest they think through and write down their questions before an appointment, or to consider asking a friend or assistant to come along to take notes or even help them assert their concerns if needed. Suggest they choose new providers based on the recommendations of their friends. For personal experience from peers is often the best. Perhaps most importantly, coach the participant to actively identify any and all accommodations they require when setting the appointment with the provider, so they are prepared when the participant arrives. As you conduct the initial assessment and subsequent updates, keep into account the participant's capacity to express and assert their needs. This slide outlines some dynamics that need to be assessed in order to develop a plan that incorporates the level of assistance they will require. Some participants will be very clear about what they need and want, while others may be unable, for whatever reason, to express these. As this slide says, the main message is to just listen, listen, and listen. Don't be looking at your computer, watching or attending to texts. None of us like that, and people with disabilities don't either. Now we're going to listen to Jim Lebrecht. We heard from him in the first webinar. He was born with spina bifida. He grew up outside of New York City and went to college in Southern California. He then moved to the East Bay of Northern California to take a job at the Berkeley Repertory Theater as a sound engineer. He recently opened his own business serving the film industry. Before we start the clip, I wanted to remind people to turn on the sound on their computers so they can hear Jim speak.
So I've never come across a situation where I felt that people were really prepared to take the best care of me. I don't believe that they knew what to do with me because I had a disability. And I think that they were guessing what they might need to do based on how they've treated all of these other people who don't have a disability or an active disability. I don't think anybody has a protocol for it. I don't think anybody knows. And it's my life and my care and the amount of pain I'm going to have and the length and time, the length of my recovery. You really should. And it isn't about the ADA or, having to follow the law or something like that. It's the right way to take care of people. Talk to me. I'm your best resource.
I love all that kid, yeah. In this clip, Jim is challenging all of us, again, to just listen. He wants to and is more than capable of actively participating in the design of his care plan. Our goal with someone like Jim is to identify a plan and then simply step aside so that he can make it happen and be available if he runs into any barrier along the way. My experience is that a participant's ability to take charge of their health care has less to do with their disability and more to do with their level of activation. It's a great tool that has been developed about 15 years ago and validated by Dr. Judith Hibbard of the University of Oregon. It uses a simple 13-point questionnaire to identify where the participant is on the journey of self-activation. We have placed a link into the chat function, or will be placing a link into the chat function for a PowerPoint describing this tool. I have found it to be extremely useful, even if not actually applying it within your plan or provider context. To understand the concepts behind it are a good way to begin thinking about how do we allocate staff care coordination time in working with individual clients. The first two steps of the care planning process are assessment and identification of needs and priorities. The remainder of the process will be discussed in greater detail in Webinar 5, Introducing Care Coordination. It is important to remember that this process is ongoing and fluid, being revised and updated as needed. In the DCC model, assessments are conducted by an interdisciplinary team composed of a nurse, primary care practitioner, social worker, and behavioral health practitioner. While not all members of the interdisciplinary team may be present at the initial and subsequent assessment at the same time, it is vital that they all conduct pieces of the assessment pertinent to their scope of responsibility. This information can be documented and shared at an upcoming team meeting. It is strongly encouraged that assessments be conducted within the participant's living setting. This provides an opportunity to see where and how the participant lives and to assess the environment to some degree. While not all members of the team may be able to visit the participant's home, these observations can later be shared with the remainder of the team. The involvement of family or care partners can be beneficial, though must be done only with the express consent of the participant in advance of the visit. I remember a couple of participants were very self-conscious of someone coming to their house to do an assessment. They didn't know who we were as they planned. They didn't know what a care coordinator was. So the first 2 times we met them in a coffee shop near their place, slowly building the trust. And then they invite us into their home. So it may take some time, you may need to work with it, but I do think being in an individual's home, it will give you great insight into who they are and what they need. As implied above, the role of the IDT will vary greatly based on the ability and readiness of the participant to assume responsibility for the health and health care. The more they understand and are able to carry through, the better they will be able to maintain or improve their health. It is suggested that the IDT expressly ask each participant how much support they want. This could be a closing conversation at the end of the assessment and can minimize expectations not being met. The number one feedback we had in a program I ran was that they didn't get enough contact from the care coordinator. So this was our response to that, is to explicitly agree on that. To be more concrete, we would ask the participant whether they wanted to be left to themselves or would call us, and would call us when they needed something, or whether they wanted us to initiate contact periodically. If they said periodically, we would jointly agree on a frequency, and sometimes even a specific day. This was especially helpful for those with significant anxiety and stress concerns. Having a strong and supportive relation will greatly enhance performance on quality measures. This also provides a context to follow up on regarding basic needs such as cancer screening, preventive inoculation, and identification of chronic or ongoing concerns. The disability competent care assessments are, by necessity, very comprehensive and all-encompassing, as you can see in this slide. It is necessary for the full team to get a picture of the participant, their goal, priorities, history, and needs. Most integrated Medicaid and Medicare programs require this level of assessment, be it the dual demonstrations or PACE programs. This assessment serves as the foundation for the care plan and the oversight responsibilities of the team. Besides the IDT members delineated in this presentation, the involvement of additional professionals may be beneficial. For example, persons with significant functional limitations may benefit from assessments by both an occupational therapist or physical therapist. It is vital that each member of the team review the entire assessment, even the parts they did not conduct, for each discipline brings a different set of skills and perspectives. From this assessment, referral to additional specialists may be needed, such as a nutritionist, an audiologist, rehab engineer, mobility specialist, or others. At this point, I wanted to tell you about someone I worked with many years ago. I will call him Tom. Tom experienced a traumatic brain injury in a motorcycle accident in his late teens. This resulted in significant functional and cognitive limitations, and he was bounced back and forth between rehab centers, hospitals, his mother's home, and even a few nursing homes. He never lasted long anywhere because he was a handful. He was angry and frustrated, and let it be known. He could be both charming and engaging, as well as highly frustrating. When I first met him, his goal was to live with his mother, to do his own cares, find a job, and build relationships. The barriers he experienced to achieving these goals were physical limitations, limited access within the house, and impulsive and socially inappropriate behavior making relationships difficult. I will tell you more about his progress at the end of this presentation. Having completed the assessment and having a good sense of the participant's needs and priorities, it is time to start developing a care plan with the participant. The plan is based upon the participant's life goals, care goals, and action steps for their accomplishment. The care plan is reviewed and revised over time based on changes in the participant's life and as new issues are identified. The individual care plan is a living tool developed to guide all involved in a coherent and consistent course of action to achieve the participant's goals. While some components listed in this slide are relatively common, the resulting care plan will be unique to each individual and provide clarity for all involved. The individualized care plan also needs to have a few additional components to ensure basic health and safety. Plans need to document any communication accommodations required. This needs to be shared with all those working with the participant. Risk management plans vary greatly based on the participant. For those with behavioral health issues, such as stress and anger management, strategies need to be developed, documented, and communicated to those around the participant to provide support as needed. For an individual who is highly dependent on equipment or others for personal assistance, emergency backup plans need to be specified and communicated. For example, a participant who requires help to get out of bed every day needs to have a plan in case the assistant doesn't show up or isn't available. For a participant who relies on power equipment, such as a wheelchair or a ventilator, they need to have access to backup equipment or backup batteries or even an electrical generator. This really competent care model calls for the participant and their team to think through and develop plans proactively. Let's get back to Tom now. Having been followed by his pediatrician well into his 20s, he was embarrassed and wanted a new doctor. His team talked with him about a couple of doctors in the area, going over what they had heard from other participants and the level of accessibility in their offices. We had home assessments for both OT and PT, who recommended several relatively minor modifications, such as a few grab bars and removal of some thresholds. And he had some home-based therapy for a few months to work on his personal care, which was a real priority for him. Being a man in his late 20s, he really didn't want his mother to be doing his cares. He participated in independent living skills training, focusing on skills such as money management, meal preparation, transportation, arrangements, and others. His personal care services were redesigned so that he and his attendant could go to a local YMCA several times a week to work out. He is currently getting along much better with his mother, and he's even reestablished his relationship with his brother and some friends from his high school years. So you can see how his life has turned around. Of course, there will be more crises, there will be more problems, but this gives you a sense of how the assessment can lead to the plan and can result in some nice outcomes. As stated earlier, care plans are living documents discussed with the participant and their IDT. Once developed, the plan goes into action until a change is needed or requested. Throughout the development and revision of all care plans, participants need to be assured that they have the right to request an alternative plan or to appeal to another person within the plan or practice or to an outside ombudsman or agency. Our experience is that conflict or significant disagreements seldom arise if there's open communication and a strong relationship of trust between the participants and their team. We all need a circle of support, be it their immediate family or neighbors, to colleagues, friends, and those we've met in community activities. that is key to health and well-being for all of us. In the DCC model, we refer to these as care partners, not caregivers. Caregivers implies a one-way relationship. We view these as natural supports who choose to participate because they want to. It is important to clarify with the participants how they want to involve their care partners, what information they wish to have shared. Their lives have often been such an open book, they may just want to regain some privacy. Mostly, we suggest communication be left to the participant to share information as they see fit. Care partners sometimes also need to be helped with establishing and maintaining mutually supportive relationships. Sometimes the participant or care partner may need a break, and the interdisciplinary team needs to attend to their needs so the relationship can be maintained into the future. They could consider an increase in personal care assistance or even a respite setting for a little while. It is also important that clear channels of communication and privacy be established between the care partners and the interdisciplinary team and other providers. Most partners are not experienced in this role and can benefit from some information, coaching, or even basic support. I have certainly seen a tendency on behalf of care partners to overshare information with the participant treatment team, interdisciplinary team, This can be disrespectful of the participant, and it is important that the interdisciplinary team not get pulled into such interaction. As stated from the beginning of this webinar, the key to health and well-being is the participant's relationship with their interdisciplinary team. The open and trusting communication will build a partnership that can achieve the goals of the participants. This trusting relationship is based on the team knowing the participant and how they have experienced their health and health care. Assessment is an iterative process conducted through a discussion with the participant and repeated over time. We would now like to open this presentation up to your questions. Please use the chat feature on the lower left-hand side of your screen to ask any questions about the content of this presentation. I will be turning it over to Jesse Mikulak from the Lumen Group to bring us the first of the audience questions.
Thank you, Chris, for that presentation. We've had a couple questions come in on the chat, and as Chris said, please feel free to add your content questions to the chat feature on the lower left-hand side, and we'll get to them as we can during this last 15 minutes or so on the webinar. The first question here, when working with a person with a disability, what is expected of us in terms of accommodations?
That is a question that ultimately your own organization needs to decide. What I think of with that is to step back and look at what is it they need. Yes, they may need, and in their living setting, they may not be able to get upstairs. Well, do they need an elevator? Well, that might make it easier to get upstairs, but elevators are also expensive, so that doesn't mean that you're responsible for accommodating that. There is some responsibility if there's a vital function upstairs, is figuring out a way to get them upstairs. A variety of alternatives are broached there. What we would do in that situation is we would call in a home modification expert who would come in and make some recommendations and get some people to kind of price out what those changes would be. So there is no general rule. The ADA does not really define that. That's really more about public accommodation. What we're really more talking about is the mindset of how your members' needs are being met. And that is something that the team and the participant needs to think through and partner to getting those met. I think that would also be a good question for the presenter of next week's webinar, a woman by the name of June Kales, who has been dealing with this very issue for over 20 years in California.
Thank you, Chris. Another attendee is asking here, well, they said they have a number of younger, under 65 individuals in their PACE program, and it's been difficult to keep up home care staffing, let alone provide backup and choice for more self-directed individuals. Do you have any advice for building resources for personal assistance?
That is often challenging, and depending on the model, whether it's going to an agency or if you're a PACE program, you're probably hiring them yourself. What I would do is trying to think this through. See if you could find an organization who would partner with you. Someone who could, whether it's another home care agency or whether it's a social service agency in your community or some other organization who could help you promote that there's people who need some services. And then I think the issue of having trouble finding people or keeping people, my experience is the issue then becomes one of burnout and frustration. And that is really directly related to training and supervision of the caregivers. Often these individuals are, as I said earlier in the presentation, really frustrated with their life. And they let that be known. A lot of younger men especially may have other interests in a relationship with a caregiver other than just personal cares. And that can be difficult to deal with in a professional relationship. So I would start looking, the first step I would do is look towards their circle of support and think of some natural supports in the community who could possibly partner with your PACE program or health plan to help identify some individuals. And I think your role in this would be to support and train them to work with your participants. I wish I had a more direct answer, but other than to assure you that you're not alone.
Thank you, Chris. Okay, the next question here is about the interdisciplinary team. How does the handoff happen between all the members of the team? In practice, many of them work in different locations and settings of care, so timely communications are challenging.
That is absolutely true, and we had several questions regarding that last week, and I think we'll also get several questions about that on our primary care presentation, which will be in 2 weeks. Because often that's where the linkage falls down, is the connection between healthcare and social service, or the healthcare and community-based care. The question then becomes, where does the care coordinator sit? That's a classic role of care coordinators, is to facilitate and coordinate that. But then where do they sit? Do they sit in primary care? Do they sit in the health plan? Do they sit in the community-based organization? There's a variety of different models that are in use, and I don't know that there's a right or wrong model in that. So what I'm aware of as the most functional is all assessments are entered into a electronic health system. Now, then you have the issue of interoperability of the electronic health records. But if there is a way that that everyone, let's just make up a situation. The primary care portions of the assessment are done in the doctor's office. Chances of getting doctors to go out to a person's home regularly are probably not good. What we often would do is we would have the care coordinator, which would be a nurse and a social worker, go to their home, do those portions first, and then join the participant with their permission at the first or one of the primary care visits to share the information. And then gather the information from primary care and make sure it's entered into the system back at the care management organization and built into the plan of care. So the issue is, how do you do that? I'm aware of in Minnesota, we actually had a large county that we co-located a bunch of staff in, and we had access to their health records. I know of another place where the health plan had partnered very closely with a primary care clinic, a system of primary care clinics, and they actually were given remote access to their physician portals so that they could enter information, send direct notes, and communicate that way. We all know the least effective way is faxing papers, because that doesn't happen. I know that there's another plan that has been working on this, and I think we're in the process of writing something up about this, where staff within the plan are being taught, coached on going to an appointment with the primary care physician to serve as that communication link two ways, and making sure that the physician knows everything else that's going on with that person. It takes a pretty strong care coordinator to do that, because doctors tend to be moving pretty fast. But if you establish a good relationship with that primary care physician or practice, they will pretty quickly come to see the value that the care coordinator can bring to them. Even as simple as the health plan has access to all medications that have been filled as recently as yesterday. And so if you can get that information to the primary care doc prior to all appointments, that's incredibly thrilling for the primary care doctor, because he or she never knows that. And so that will be a way for them to see very quickly the value that can bring. So there is no easy answer because of the interoperability issue. It's really figuring out your own setting, looking at where your greatest opportunities are, and establishing those unique linkages that will accomplish the goals that you believe are important.
Thank you, Chris. Next question here is looking at the money side of the issue. It says, I would love to be able to have a full team work with each of our members with a disability, but we simply can't afford that level of intensity of touch. I do believe the DCC model would provide excellent care, but how do I make it work financially?
That's ultimately the issue. And I totally understand that. In some of the pioneering programs that the DCC model was based on, they were severely disabled adults with severe physical disabilities. Therefore, the capitations the plans received were high. So they were able to do a level of touch that plans with a broader and larger base can't do. At the same time, all the people that these highly target, all these people who are in these pioneer programs exist in these larger plans. The key to it is figuring out who are they and how do you allocate your staff time to those individuals as needed, because it's not going to be kind of a one-time thing. I know that I've heard of a plan that basically has 4 levels of care coordination they provide. One level that had, I believe, about 60% of their members had, I don't know what their language was, but very low touch. Where they just basically, as I said, you run behind them and you wait for their calls. They were placed in that group based on the assessment, based on, they actually are beginning to use Dr. Hibbert's tool, but it was pretty clear that they could handle it themselves. So, therefore, you're taking 50% of the people off the base right there. So then you're dealing with 40%. Of that 40%, you probably have 10% who are in crisis at any one time. They may be in the hospital. They may have lost their housing. Whatever it may be, they need intensive help quickly, but they won't need that. They might be able to go back to that 60% group fairly quickly once they're through the episode at crisis. So that group, that plan had a crisis team that would deal with the person, stabilize them, get them back to a good setting, and then they'd work on the handover back to the team that was best for them. The remainder were in a medium and high care coordination team where they had different ratios of staff. The high is someone who may be on a ventilator, has high utilization, has high history of ER usage, may have some serious mental health or chemical health issues, and therefore just needs a lot of ongoing care coordination. And then the lower one, maybe just those who can't just self-direct. They need maybe a monthly call. Sometimes that monthly call may be from an office-based person, just kind of checking in, how you doing, what's going on. Half-hour call at most, that may be all that person needs. So all I'm doing is giving you an example of what one plan did, but the message behind this is simply that in the initial assessment and subsequent interactions, the goal is to figure out what is it they need and then provide that. Because you're right, you can't do the intensity that we've laid out in the model for every one of your members. That's not financially viable. So the issue is you have to work on allocation of staff resources.
Thank you, Chris. We have time for one or two more questions here. The next question here, so do you see all members in some level of care coordination, I assume within the DCC model, but the person is asking, isn't care coordination voluntary? Many members or patients don't necessarily want to engage despite our efforts to engage them.
That's a good question. Absolutely, some people refuse it. They may refuse it because they don't trust. I mean, most care coordinators are based on health plans, and people with disabilities don't have a lot of trust in health plans. They're kind of nervous about it. So you're right, there may be refusal. What we found is many just don't understand what a care coordinator is, because they tend to see it as either a pejorative social worker who's going to come in and tell me what to do, or a doctor who's going to treat me medically as a diagnosis. So, no, I don't think every member needs that. I think what's important then for those people, if there's consensus between the member and the team about whether they need care coordination or not, then that's fine. They can kind of go off to the side. I mean, likely the plan would require that you do an annual assessment or something. So there'll be some frequency of connection. But then I think the issue, if there is dissonance between what the member perceives or wants and what the care coordinator team thinks they would benefit from, then all you can do is kind of keep going at it subtly and slowly. You may also need to wait until you're aware that they were in the ER last week. And then you can call them up and say, so I understand you were really sick last week. What happened? And or a hospitalization. So you may need to wait until there's some episode of care that you can help them see how the care coordinator could have helped them with that. So by no sense is there a requirement for that other than some assessments. And ultimately, if they don't want to be assessed, you can also just document that, obviously. But our experience is once you establish that relationship, they do. The other thing we do, we did actually in Minnesota, I'd forgotten this, is that we would work with some providers who they had high levels of trust with. In one place, it was with the MS Achievement Center. In another place, it was with a doctor. that they had been seeing for quite a while. If the doctor recommended something, or the MS Achievement Center, that was like almost a done deal. Then, oh, okay, good, I'll do that, I'll follow up. So it's the kind of having the provider who they trust with their arm around you as a care coordinator to at least get your foot in the door to figure out what's going on and how you can help them get what they need.
Thank you, Chris. Okay, I think we have time for one more question. So the next question that came in here, what do I do if I have concerns about the relationship between a participant and one of their care partners?
Oh, this is pretty common. And the concerns that we've seen, some of them are financial, some of them are sexual, some of them are kind of more abusive in terms of bullying and that kind of thing. Ultimately, the organization that you work in has to have your own policies of how you handle this. I would always suggest that you start by engaging with the participant in order to have that, to bring that concern forward. Ultimately, there may need to be some reporting to an authority if you think there is an abuse that you're not able to address. So there's not an easy answer in that sense, but it does always start with a conversation. When it comes to the vulnerability issue, the person may feel, if I assert myself with him, he may hit me. Well, then we need to talk to them about, maybe we should talk to you, maybe we should look at to see if there's another caregiver you could get in here, or would you like me to talk to him about how he scares you? So that's one thing. Let's say there's sexual. The team sees that there's some sexual issues. Well, you don't know where those sexual concerns are coming, or initiations are coming from. Are they coming from a caregiver, or are they coming from the participant? I've certainly seen it both ways. But again, it's the whole mindset of participant first. Start with talking with the individual about some of the concerns you've seen and go from there. Ultimately, there are laws in every state about reporting of vulnerable adults. Many states have very narrow definitions of what a vulnerable adult is. So in some situations, you may have no choice but to report it to authorities. But the intervention, I would encourage you to try to do at the individual and team level, if at all possible.
Thank you, Chris. I think that's all the time we have for questions today. For anyone who we weren't able to get to your question, please feel free to email us at ric@lewin.com, and we'll try to follow up with you individually. And I'll turn it back to you, Chris, just to finish off these last few slides.
Great. Thank you for your questions today. I appreciate it very much. We're going to wrap it up. Please send your feedback to the link on this slide. And after the survey, we would like to have that within a week if possible, preferably within the next hour if you could. Again, I'd like to call your attention to the resources that we have online, the Resources Integrated Care site, and Disability Competent Care Self-Assessment Tool. Next week at this time, we will have our third webinar, Disability Competent Care. That will be followed by Disability Competent Primary Care, and then we'll go into care coordination. All three of those were issues that came up throughout my presentation, and were certainly present in their conversations and the questions from the audience. Each of them will have an expert presenter who I think will bring a great deal to this discussion. Again, I would like to thank you and the Center for Medicare and Medicaid Coordination for sponsoring this webinar and the entirety of the Disability Competent Care work. Thanks for attending.
Ladies and gentlemen, at the end of the webinar, a post-conference survey will appear on the window behind the web presentation. Your feedback is very important to us, so please submit your survey. If you close the survey window or do not see it, a survey will be emailed to you in 24 hours. We request that the surveys be completed within 1 week of today's event. This concludes today's webinar. Thank you all for attending.